Looks like everyone is on. Good afternoon. And again, welcome to our first Empowering NBC Voices webinar session. My name is Lauren. I am the project coordinator for the breast cancer program here at Washington University. And I wanted to start by sincerely thanking each and every one of you for being here today. We truly appreciate your time and commitment to supporting and amplifying the voices of those living with metastatic breast cancer. We're honored to have two incredible presenters today. We have Dr. Catherine Clifton, a breast medical oncologist here at Siteman Cancer Center, and Jessica Vanderlyn, a licensed clinical psychiatrist at Siteman Cancer Center. They'll be sharing their insights on mental health in patients with breast cancer, as well as mental health and cancer. We're also thrilled to welcome Josh Newby, founder and executive director of Teresa's Research Foundation, who will guide and moderate the conversation. Thank you so much, Josh. Following today's presentation, we'll have a 30-minute town hall session. This is an opportunity for open conversation, questions related to today's topic, and the sharing of your experiences. And please note that this webinar is being recorded. However, the town hall will not. Before we begin, I want to remind you that I am the direct contact for the Empowering NBC Voices webinar series. So if you have any questions, would like to give feedback, or just would like to connect after the event, please do not hesitate, to reach out. And additionally, there is a fully anonymous Zoom survey that will appear in your web browser following the conclusion of today's session. We would truly appreciate it if you could take a few minutes to fill it out and share your feedback. It'll help us tremendously with the next few sessions. And with that, I'll hand it over to Josh to get us started. And thank you again for being here.
Awesome. Thank you so much, Lauren, and thank you so much, everyone, for joining us today. We're really excited to kick off this webinar series with the breast program at Siteman Cancer Center. We've been working on this project together for the better part of a year now, and I'm really excited. This is kind of the first of many things we are working on together for patients. And I just think this is such a great first topic that the organizers have selected from the Siteman team. I've seen firsthand. My mother, when she was alive, was treated at Siteman and benefited from a lot of the services that they'll talk about today. And I've personally benefited from them as well, and I'm so grateful for them. And so, as Lauren mentioned today, we'll have two presentations, and then the thing that will make this webinar a bit different is that we are having a town hall where we want to engage with patient advocates and patients and the community, and get your input and let us know your experiences. And then, as Lauren suggested too, please complete the survey afterwards, because we're going to be working on this constantly to improve this in any way we can to make sure that it's a benefit to you. Lastly, I do just want to make a couple of quick shout outs. I want to thank Martha Carlson, who's on this call. She's helped share this out through some of her different networks, especially with the nonprofit called Share, which has been great. And then Lynn, who's on the call, does a lot of work for the foundation and is an NBC patient, and we're so grateful for her help. So just really excited to get this going. And so I think we're going to start with Dr. Clifton, if I understood correctly. So Dr. Clifton, take it away.
Okay, just starting to share my slides. Switch. Okay, does that look good for everyone? Perfect. All right. Thank you so much, Lauren and Josh. Thank you for having me here today to speak about this important topic. So I will start by just kind of reviewing the prior breast cancer care model. We used to think of treating patients with breast cancer with these three modalities, so surgery, medical therapy. So that's where I come in as a medical oncologist, and radiation. But we really know now, that cancer affects the whole body and the whole person. So now we're starting to think of breast cancer care as a more all-encompassing model to include these other domains. And today I'll be focusing on mental health. So obviously there's lots of topics in mental health as it relates to patients with cancer, but we'll focus on these four big ones today. So depression, anxiety, loneliness, and then social isolation and social support. So we'll start by talking about depression. We'll start by defining depression, talk about how prevalent it is in patients with cancer, the consequences that depression can have, and we'll touch on some solutions. I think it's important to define depression because this is often a term that's used pretty frequently colloquially. So we can be talking about a depressed mood, which is feelings of sadness, despair, anxiety, discouragement, hopelessness. And this can, of course, be a very normal response to a cancer diagnosis or cancer journey. Depression, though, can also be a syndrome, and that's what we'll be referring more to this in this talk today. So that's when it's accompanied by significant weight change, sleeping too much or too little, fatigue, feelings of guilt, worthlessness, difficulty concentrating, or thoughts of death or suicide. And then there's also depressive disorders, which are psychiatric disorders. These are diagnoses that have to meet a specific set of diagnostic criteria, such as major depressive disorder. So, a little bit of background on depression. We all know that cancer is a commonly feared diagnosis. It's a very common diagnosis. It's also associated with lots of unknowns. Many patients know someone else or many people who are diagnosed with cancer, unfortunately. Cancer has been shown to generate more distress than non-cancer diseases that have poor prognosis. And the distress that's caused by cancer can lead to depression and or anxiety. The rates of depression can be very high in this population, so up to 3 times higher than the general population. And some studies have shown that depression in patients with cancer is as high as almost 50%. And it can vary by the cancer type, the cancer stage, the age of the patient, and gender. Some other risk factors for depression is patients who have poor coping strategies or prior mental illness. Patients who are at lower risk are those with strong support systems or optimistic viewpoints. So what are the consequences of depression and why does it matter? So there's many reasons. Depression can affect treatment participation. So in one study, only about half of breast cancer patients with depression accepted and started chemotherapy compared to 92% without depression. And of course, this can lead to poor outcomes and higher mortality if patients aren't accepting treatments. Depression can also decrease quality of life. So some studies have shown that breast cancer patients who have higher pre-chemotherapy levels of depression also have increased levels of depression during treatment and worse quality of life. When patients with cancer are hospitalized, depression can increase the length of stay in the hospital. And patients with cancer and depression, unfortunately, can have worse mortality. So there was one study that looked at over 31 studies and found a 25% higher mortality rate in patients who had depression, and almost 40% higher mortality in those with major depression. And some thoughts to as why we talked about earlier that depression can lead to that non-participation in treatment, but there may also be some biological reasons as well. So chronic stress may lead to the increased cancer invasiveness and reduced tumor surveillance, basically meaning the body might have a harder time fighting off the cancer. And I thought this study was very impactful as well. It showed that the treatment and improvement of depression in patients with metastatic breast cancer was shown to significantly prolong the median survival time by 28.5 months. So that's over 2 years compared to patients that experienced worsening depression. So that's really better than, a lot of our newer medications. So it's really significant and shows how important it is to identify and treat depression in patients with cancer. So part of the solution is first recognizing depression in patients with cancer because it might present differently compared to patients without cancer. It can present as fatigue, loss of appetite, weight changes, difficulty with thinking or cognition. And this is sometimes confused for side effects of the treatment or the cancer itself. So there's different ways to screen for depression. This is a distress thermometer, which can just be an initial screening to let providers know that there might be some distress in the patient. And then this is the PHQ-9, which is a screening specifically for depression. It's important that other medical conditions like low thyroid, vitamin deficiencies, anemia are ruled out. And then it's also important to treat pain or cancer related treatment side effects, as those could mimic depression. So there's medical therapies for depression. Kind of the backbone of therapies are the SSRIs, or the selective serotonin reuptake inhibitors. These are medications like Prozac and Zoloft. So these block the uptake of serotonin, which is often related to mood. They increase the activation of serotonin receptors and can been shown to improve mood. There are several SSRIs that have fewer drug-drug interactions and that are considered the best first-line treatment option. There are some older antidepressants, such as the MAOIs, the tricyclic antidepressants. These often have more side effects and interactions and might be used to treat treatment-resistant depression. There's the SNRIs, like venlafaxine. We often use this medication in patients who are on tamoxifen because it interacts with tamoxifen the least. There's some other medications like bupropion, but this has activating properties that could worsen anxiety. Mirtazapine can actually cause sleepiness, so these are often not used as frequently. And then there's non-pharmacological treatments that we'll also touch on later with our second talk today. But psychoeducation is used to build knowledge and coping strategies with regard to cancer. And then there's cognitive behavioral therapies. These work to identify and equip patients with the skills that can then help them overcome these maladaptive thought patterns and encourage emotional readjustment. And both of these have been shown to be effective in improving depression, as well as quality of life. These are some other strategies, such as problem-solving therapy that focuses on creating, implementing, making solutions for problems for patients, including relationships. And then there's acceptance and commitment therapy that teaches patients how to tolerate difficult thoughts without being overwhelmed. I also wanted to talk a little bit about integrative oncology. So integrative oncology, it's a field of medicine that combines our conventional cancer treatments, so what we talked about earlier, such as surgery, chemotherapy or medical therapies, and radiation, and it combines these with complementary and alternative therapies to try to improve the well-being of cancer patients. And it's becoming more common. So it rose from about an estimated 25% in the 70s and 80s, now to almost 50% use in the 2000s. So the Society for Integrative Oncology and ASCO, which is the American Society of Clinical Oncologists, got together and came up with specific guidelines about integrative oncology care, specifically in patients with anxiety and depression. So the first recommendation was for MBI, which stands for mindfulness-based interventions. So these are things like meditation. And so you'll notice with these recommendations, the societies give two recommendations. One is based off of the quality of evidence, and then one is the strength of the recommendation. So the recommendations for these mindfulness-based interventions, they said that the quality of evidence after reviewing the literature was high, and the strength of the recommendation was strong. So these MBIs received the strongest recommendation after both societies reviewed the literature. There were some other things that came up. So yoga, specifically in patients with breast cancer, did have intermediate quality of evidence and moderate recommendations. Music therapy, the quality of evidence was not quite as good. It was low, but it did have a moderate recommendation. Relaxation therapies also had low quality of evidence and weak recommendations. Reflexology, so this is referring to applying pressure to specific pressure points. This also had low quality of evidence and really weak recommendations. So this is a summary of these complementary and alternative medications that were recommended in patients specifically with depression. So again, you see the intervention with the highest quality of evidence and the strongest recommendation was these mindfulness-based interventions. Also, you'll notice expressive writing. That's things like journaling. That was specifically not recommended by the society. And that was because after reviewing the literature, they felt that there was no evidence that this was helpful for patients in the studies that were presented. So next we'll discuss about anxiety. So anxiety can be very normal. It's potentially just a normal reaction to situations that people perceive as threatening. And it can have some positive qualities. It can motivate patients to adhere to intense, and also often aversive anti-cancer treatments such as chemotherapy. However, if anxiety becomes overwhelming and excessive, it can become a problem. So generalized anxiety disorder, this is when you have excessive worry and anxiety that are really difficult to control. It's causing distress, impairment, and that's happening on most of the days. And then there's adjustment disorder with anxiety. So this is when you have distress really out of proportion to the stressor. And again, it's referring to anxiety that's causing significant impairment. So just like depression, anxiety can be very common in patients with cancer. And the estimated rates are anywhere from 12 to 34%, with higher prevalence specifically in patients with pancreatic and lung cancer, in female patients, and in younger patients. And, majority, 2/3 of patients with cancer who report that they have anxiety had no prior history of anxiety prior to cancer. Usually anxiety, the rates can be highest both at the time of diagnosis and at end of life. And just similar to depression, it's associated with a poor quality of life. So this is just, a schema that shows the cycle of anxiety in patients with cancer. So you see these contributing factors. So there's predisposing factors. So if patients have had a history of anxiety, if they're socially isolated, there can be specific cancer-related fears, such as the treatments, existential concerns, such as the disease course, concern about suffering, concern about death. There can also be concerns specific to the disease and treatment factors such as side effects, and then comorbidities. So what else is going on in the patient? Is the patient experiencing pain, fatigue, or other symptoms? All of these can contribute to anxiety. And then this can lead to this maintenance cycle. So where patients are constantly scanning for threats, are worried about things, watching for things. And then this leads to coping. So poor coping skills, such as avoiding or trying to escape the situation, or efforts to increase security, such as constant checking. So trying to constantly check on the state of the cancer, perhaps more frequently than advised by the oncologist. These in the short term can lead to emotional relief, but the long-term consequences that they can just reinforce this sense of threat. And so then that leads to this cycle and maintenance cycle of anxiety. Specific to patients with cancer are these terms. So fear of progression, this is in patients with cancer during active treatments, worried about that the cancer could be getting worse. And then there's fear of recurrence, which is specific to cancer survivors who are worried about the cancer coming back. And these are really significant cancer-specific anxiety-related clinical conditions. And the amount of patients who have advanced cancer and anxiety around death has been estimated to be very high as 80%. There's also this term called scanxiety. So this is referring to anxiety that comes before, during, or after cancer-related imaging. And the scan results themselves can be a reminder of patients of their diagnosis, can cause uncertainty about their results. What does this mean for the disease or future treatments? And then there's concern and anxiety about the scan itself. So patients might be not familiar with the equipment. They may get claustrophobic or uncomfortable or worried about the amount of radiation that they're receiving. Risk factors for anxiety are very similar to the risk factors we talked about for depression. So there's specific types of cancer that are associated with higher rates of anxiety, breast, ovarian, and lung. The stage of cancer can also cause more anxiety. Treatment-related factors like the need for chemo or radiation. If patients are experiencing pain, this can lead to more anxiety. Patients have other illnesses or a history of anxiety. And then this, of course, often coexists with depression. Anxiety can present differently, so it can be really a spectrum. It can be anywhere from patients presenting as overtalkative to being withdrawn, and it can cause physical symptoms like palpitations or heart flutterings, sweating, abdominal discomfort, diarrhea. So this is a tool that can be used to screen anxiety called the GAD-7. And the consequences of anxiety and why anxiety is so important to be treated as well, similar to depression, anxiety can lead to poor quality of life. And it can also affect a patient's cancer care. So patients who are anxious, they might have blood injection or specific phobias and claustrophobia, and this might limit a patient's ability to tolerate procedures. So there are medications that can be used to treat anxiety. So benzodiazepine, so these are medications such as Xanax, Valium, Ativan. These are frequently used in oncology for anxiety, specifically panic, such as panic attacks. They can also be used at times for nausea or insomnia, but they do have side effects. So they can worsen fatigue and concentration. They can complicate things like alcohol abuse. And for some patients who are elderly, they may actually have paradoxic reactions. So these medications are really best used to provide immediate relief, but then are better if they're carefully discontinued in patients. And one trial of alprazolam, which is Xanax, in patients with anxiety found that both alprazolam and the placebo groups had a sustained reduction in anxiety, but there was no difference between those who were receiving placebo and those who were receiving the Xanax. So really the better solution for the long-term treatment of anxiety is the antidepressants that we talked about earlier. So really in the general population, the SSRIs and then the SNRIs like venlafaxine, these are the best first-line agents for treating anxiety. There are some other medications such as mirtazapine, low-dose antipsychotics, gabapentin, but these don't have FDA indications for treating anxiety, so they have not really been well studied in patients who have cancer and anxiety, so not first line. There are other methods to treat anxiety, such as psychosocial interventions. There's cognitive behavioral therapies. So these are goal-oriented and they focus on rehearsing skills for trying to change thinking patterns and behaviors. Supportive expressive psychotherapy refers to a non-directive approach, and this allows patients to process their cancer-related experiences. And then there's mind-body approaches that include relaxation. And so these can be introduced alone or integrated into other interventions. And so this was a review of the Society for Integrative Oncology and ASCO recommendations that we discussed earlier. So they also gave their recommendations for treating anxiety in patients with cancer. And so again, we see the highest quality of evidence and the strongest recommendation for those mindfulness interventions. Less evidence for yoga, but still some evidence there. Less for music therapy, and not as much for the relaxations therapies or reflexology. There were no contraindications for mindfulness-based interventions, but they did notice that you needed to be careful in patients with a remote history of PTSD. There are many other different modalities, and it's complementary alternative medications and therapies that are being studied for anxiety, but they noted that there's inconclusive evidence for all of these therapies, such as light therapy, massage, supplements. And so really they did not recommend any of these and said that more randomized trials are needed at this time. So next we'll move on to loneliness. So loneliness is really a subjective feeling of separation from others. So it's subjective. So this is why someone could feel lonely in a crowd. And this differs from social isolation, which is the absence of interpersonal interactions. So loneliness is really this perceived sense of social isolation, and then it results in a person feeling unsafe. And this can lead to hypervigilance, stress, anxiety, anger. It likely has an evolutionary benefit, so humans are social creatures. We need each other to survive. So in the past, those individuals who are socially isolated would feel lonely and then, in theory, would be more motivated to increase their connections with others. Loneliness also activates this hypothalamic pituitary adrenal axis. And this is this important biological axis that we have that's involved in the stress response. So that you can see that loneliness increases cortisol level, which is generally thought to be, not a good thing for many diseases, including cancer. Loneliness can also affect the sense of meaning and purpose and then negatively influence behaviors. So this is a very powerful figure that shows the negative consequences of loneliness. So loneliness has been shown to increase depression and anxiety. It can decrease performance at work. It's a risk factor for functional decline, and it increases the risk of heart disease, stroke, and dementia. And then I think this is very powerful, but loneliness has been shown to increase the mortality similar to smoking 15 cigarettes per day, and is shown to be a risk factor for premature death. Loneliness has been increasing in recent years. So a survey from 2023 showed that almost a quarter of people in more than 140 countries reported feeling lonely. And there was this trend going on even before the COVID pandemic. And it was thought to be due to declining social connections, decline in the size of the family and marriage rates, and community involvement. And there is kind of this concurrent influence from technology. And so we often think of technology as bringing us together, but it's actually been shown to decrease in-person interactions as well as the quality of interactions. And social media has been shown to decrease self-esteem. So one study showed that people who had higher rates of social media use actually felt more socially isolated. So I think this shows that sometimes, these support groups on social media might not have the quality of interactions as an in-person group. This is specifically looking at loneliness in individuals with cancer. So we know that these individuals have unique sources of loneliness. They might not feel understood or supported by family or friends. They might be worried about sharing their cancer-related concerns. And one study showed that higher loneliness was associated with worse survival in a cohort of over 3,000 patients with cancer. So I think this figure is very powerful. So this is a survival probability. So on this figure, lower is worse. So the light blue is patients with severe loneliness, and you see they have the worst survival compared to the dark blue, which is patients with low or no loneliness. So in 2023, the Surgeon General issued an advisory trying to increase awareness of the loneliness epidemic. And he specifically recommended increasing social connections using these kind of 6 pillars. And I think 2 are really relevant to us in medicine. And one is mobilizing the health sector, and the other is deepening our knowledge of loneliness and isolation. So as healthcare workers, it's important for us to recognize the importance of social connection and of loneliness and receive formal training in this area. Insurance companies could reimburse for the time used to address these issues, and it could be better incorporated into our notes and into the electronic medical record. I think it's also very important to educate patients about how serious loneliness can be and the importance of social connection. So one study found that less than 20% of individuals who are lonely recognized it as having potential consequences. And then we can recommend interventions. So these are just some examples of interventions that have been shown to help loneliness in patients. So there's social facilitation. So this is really social groups, so interactions with peers and groups, psychological therapies, which these are therapies that are delivered by trained therapists. And then there's healthcare and social care provisions, which is referring to when a healthcare professional helps support individuals who are lonely. There's animal intervention. So these are dog and cat companions. There's befriending interventions, which focus on making new friendships. And then there's leisure developments, which focus on developing new skills or leisure activities. And then I will just briefly end on talking a little bit about social isolation and social support. So social isolation is the absence of interpersonal interactions. And then we know that patients with cancer who experience social isolation have worse outcomes. So you can see these are models of these mice. And so then the mice that has another mouse that has social interaction is secreting oxytocin, which has been shown to suppress cytokines, which is basically something that could cause the cancer to grow. So it's been shown to help stop the cancer from growing. Versus the mouse who is isolated by himself is secreting these glucocorticoids. So these can lead to the immune system being suppressed, which then can result in the cancer surviving and proliferating and growing. So these are some of the thought process of, what's going on biologically of why social isolation and social support are so important. Social support can be qualitative, so this can be kind of the perceived meaning and value that people attribute to their relationships. And it can also be quantitative, so the amount of social networks you have, including how long you've maybe had these relationships, how in depth the relationships are. And we know that lack of social support has been shown to be a risk factor, specifically for experiencing toxicity or side effects in patients with breast cancer who receive chemotherapy. And so some solutions are, which Lauren will talk about later, are future support groups. So now thank you. I will turn it over to Dr. Burley.
Hi, everyone. Good afternoon. While I share my slides, I'm going to invite you to take a moment and write down any questions that you have for Dr. Clifton. Usually when we go through this, there's a lot to take in, so I don't want you to forget any questions. And we will also save about 30 minutes at the end for a conversation, so you'll get a chance to answer those questions. I want to make sure that you have them written down if you need. So I'm presenting on mental health and cancer. I'm Dr. Jessica Vanderland, a clinical psychologist at Siteman Cancer Center. And what I do is I treat patients with the emotional needs that come along with cancer. So Dr. Clifton did a fantastic job of giving us a good overview and where to start. So I'm going to follow with a little bit more detail about how we treat mental health and cancer. I'm also really excited to be here because not only is mental health and cancer what I do and what I love to share and talk about, I'm excited that this whole conversation today is really about mental health and cancer. Sometimes it's left to the back burner a little bit, and I'm just excited that today it's not. We can focus on it. So as Dr. Clifton said, and as you all know, as we all can assume and understand, cancer is distressing. This is a visual from an NCCN meeting about cancer and distress. I personally practice in the field of psycho-oncology. So that's a specialized field of cancer care focused specifically on the behavioral, emotional, psychological, psychosocial needs of cancer for patients and their loved ones. So I'm a psychologist at Siteman, meaning I see patients individually and in groups for psycho-oncology or a number of mental health needs, as well as caregivers. We know that caregivers are a huge part of a patient's experience with cancer. And what we treat is longer than this list, but I want to give you like a bigger taste of what we treat. So we talked about anxiety, depression, and loneliness already, but there's more that we do treat. So fatigue is something that's often kind of coexisting with depression or side effects from cancer. So is pain and insomnia. So there's a lot to think about here. Scoot ahead real quick. All right, and then how do we practice? So what we're doing today is actually practicing psycho-oncology. This is me providing you some education, some tips, maybe some tricks to care for yourself in this way. Psycho-oncology is often completed or provided along with your medical care. Like we know, mind and body is so connected that we can't truly separate them. Psycho-oncology is sometimes done in the community or sometimes at your cancer centers. So at Siteman Cancer Center, I am part of the faculty, and meaning I can be part of somebody's care team, but there's a lot of national organizations that we provide or that are available too, that offer types of support. I'll leave this list up later. So I have this list on another slide, but here's just a few fantastic resources that really speak to and support the whole person going through cancer. So we have everything from a huge national organization like American Cancer Society that provides a lot of programming for cancer patients, their families, their loved ones, both for physical, medical, and mental health. They also have a new app that has a lot of great resources like mindfulness on there. So there's a ton of options. And then there's more local organizations like Cancer Support Community that's also national, but has specific locations. Immerman Angels, I've had great success with connecting patients here, and they give you a match. They match you with somebody kind of as close to in your shoes as possible, and that person acts as a mentor through your cancer experience. I've also had patients volunteer for Immerman Angels too and have a wonderful experience. So there's a lot of organizations out there. Again, I will share this again later. All right, so I provide psychotherapy. That is some of what Dr. Clifton talked about. As she said, that's provided by a trained professional. So somebody who has a license as a psychologist or a social worker, psychiatrist. Those providers all do provide talk therapy, and that is one component of taking care of somebody's mental and emotional well-being. In psychotherapy, we do things like CBT and ACT. Dr. Clifton also spoke about those. Mindfulness, I will give you some great information about that today. And these can be an individual therapy, group therapy, online, on Zoom like this, or in person. Could be short-term, maybe 3 sessions over a month, or maybe once a month for a year. It's very, very dependent on a patient's needs, just like your cancer care is dependent on your needs. So mindfulness. One of the best things about mindfulness is that it's so approachable and so accessible to all of us. So I'll walk through a couple very brief exercises with you today, but also you have some in your list of resources if you want to start practicing this. There is a mindfulness-based cancer recovery program. This was developed by Linda Carlson, based on John Kabat-Zinn's work in mindfulness-based stress reduction. So this is adapted to a cancer patient population. We provide it here. Dr. Tippy on my team is starting it, I believe, next week, but we offer it a number of times a year. It's an 8-week course where you learn a mindfulness practice or skill every week. You have some homework to practice it. You come back together in a group, and it also creates not only a new skill for you, but that connection that we've been talking about too. So that is I really recommend that as a program if there's something that you can find like that near you. In general, we know that mindfulness is great. We know it impacts so many parts of our lives: anxiety, depression, sleep, insomnia, so sleep problems. Also, there's been plenty of research showing that it improves immunity and how we process fear and anxiety. So there's a ton of benefits. I don't think I need to convince you of that, but I just want to remind you of that. We also know that mindfulness is something that has been around for a very, very long time. So mindfulness is the intentional, accepting, and non-judgmental focus of one's attention on the emotions, thoughts, and sensations of the current moment. We are so often going from event to event, multitasking, thinking about 4 things at once while also checking email, that we're not truly mindful. Mindfulness allows us and trains us to be more focused on what we're doing in that moment. However, that can sometimes come with what seems like a downside. So if I'm asking somebody and I'm practicing mindfulness with somebody who's in a lot of significant physical pain, you might want to say, oh no, I don't want to do this. I don't want to be any more aware of that pain. However, with mindfulness, an awareness of the pain also allows for other awareness. So truly practicing mindfulness allows you to be more present in a lot of moments. And people often find such benefit in managing the pain, even though they feel like they're paying more attention to it. There's so much more benefit in addressing pain, or that goes to anxiety or fear or depression as well. Mindfulness is not pure relaxation. Relaxation is a component of mindfulness sometimes. Relaxation may be something that I'm teaching patients as it's a great way to address stress in our life, but mindfulness takes it a bit further. It's really cultivating a good mind and body connection. There's a few kind of core components of mindfulness, so I'll just ask you to take a look at these. And some of them are a little tough, right? So this idea of acceptance or letting go, we're not often great as human beings, no one in particular, but we're not often great of just accepting things that are coming our way. But there's a lot of benefit in that. I'll talk about that a little bit more. So just briefly, here's a quick breathing exercise that you can do at any moment. That's another benefit of mindfulness, is it's often not something that you need to sit in a dark room and close your eyes for. You can do this anywhere. I often recommend for patients to do a brief mindfulness exercise when they're standing in line at the grocery checkout or anywhere. It's not something I want you to necessarily do in your car while you're driving, but almost anywhere else. It's a great opportunity to practice mindfulness. The more it's practiced, the more helpful it is. It's not something that I want you to practice only in times of great stress, because then there's an association that our body makes with that. We want mindfulness to be practiced regularly so that when you are in times of great stress, you can return to it and it'll do its job, kind of like practicing for a sport. So mindfulness is often practiced in medicine. Like I said, there's mindfulness-based cancer recovery programs. Specifically, there's a lot of similar programs in other diseases. Mindfulness-based stress reduction was actually developed by John Kabat-Zinn quite a long time ago at a hospital in Boston for people with chronic pain. So that's often where it's used as well. All right, so moving on from mindfulness. Mindfulness is a great treatment or part of treatment for depression, anxiety, loneliness, and other things. But now we're going to move on and talk about depression for a bit. As Dr. Clifton said, this occurs along a spectrum. It's more than just sadness. There are a lot of symptoms of depression that we actually sometimes confuse with other things happening. So they may be side effects of treatment or other parts of a disease process. So this diagnosis of depression is sometimes more difficult to make in patients with cancer, and it's really important that we pay attention to all these pieces. However, when we do diagnose it, or if we see any depressive symptoms, it may not fully be a full depression diagnosis. It's okay that we can still treat the symptoms to find improvement, to make you feel better. So there are a ton of treatments for depression based on my work. So as psychotherapy, we have cognitive behavioral therapy, which sometimes includes problem-solving interventions, which is just like it sounds. Sometimes two heads is better than one. I usually don't have better answers than anybody that I see, but sometimes just problem solving and brainstorming is very helpful. There's a lot more to CBT too, and I'll walk through that. ACT, acceptance and commitment-based therapy, there's growing evidence in that. That really grew out of cognitive behavioral therapy, but is a newer model of treating mental health conditions, specifically anxiety and depression, and a lot of other things, but in cancer. And then we explore some existential concerns, include some mindfulness and relaxation. Make sure that you're doing things that are meaningful to you as well as productive. So some activity scheduling, working on social support, and as Dr. Clifton mentioned, there's also medication. As a psychologist, I do not prescribe medication. That's usually done by psychiatry or your medical team, but that is often used in treatment of depression. So we're going to talk about CBT quite a bit towards the end. So CBT, cognitive restructuring, and enjoyable activities that we're going to kind of plan for. So keep that in your mind. I'm going to talk a little bit about anxiety now. Anxiety is also extremely common in cancer. It's even more common than depression. Anxiety is something that occurs along a whole spectrum. I often tell patients, I would be a little bit surprised if you didn't have some anxiety after this new diagnosis or throughout a diagnosis. That doesn't mean I want them to have a generalized anxiety disorder. However, some concern and worry, anxiety, as things change in your medical prognosis, as things change in treatment, is totally normal. So I would be a little bit concerned if there wasn't that connection with reality. Anxiety is diagnosed when it becomes really problematic, when it gets in the way of you getting to enjoy your life or do things that are important to you. And that happens a lot. Sometimes that's avoidance. Sometimes that's excessive worry or rumination, like keeping you up at night. You can't shut your brain off, so that becomes problematic. Sometimes it's an irritability with people, with other people, or in your body, or restlessness. And then as Dr. Clifton mentioned, there's scanxiety, which is unique to cancer, but a very real problem, and fear of recurrence. Anxiety about cancer or health is also a little bit more specific. So sometimes when I'm suggesting a patient seek treatment for anxiety and cancer, I want to make sure that they're seeing somebody to treat that anxiety that understands health psychology, because this is not a typical anxiety sometimes. This is a very realistic fear that we have some different ways of dealing with. Anxiety in health is often occurs with avoidance and safety behaviors. So we're avoiding places that might remind us of a treatment. If you have what you feel like is some disfigurement to your body, you might avoid going certain places. I've had a lot of women that I work with avoid going to the beach or wearing a swimsuit again, because that feels like it's something to keep them safer. Safety behaviors are like avoidance light. So instead of you're totally avoiding something, you do a lot to cover up. So again, if we're talking about some body image concerns, instead of never wearing a swimsuit again, it's making sure that you have a lot of coverage when you wear a swimsuit, or that you cover up, have some bathing suit cover-ups when you go to the beach or something like that. These are things that seem helpful in the moment. They relieve what feels like anxiety in the moment, but really they make it harder and harder and harder to keep engaging in your life. So they're things that we want to tackle early on, and often are related to some exposure. So you trying these things out, not on your own, you don't have to do it by yourself, but having somebody support you in making a good plan to tackle some of these things. So I told you to keep CBT in mind. That is another piece of management of anxiety. We do a ton of that. ACT is actually even better for anxiety related to cancer. And that's really based on kind of how the mechanisms, how the therapies are working, what mechanism they're working on. We have exposure therapy, social support, and medication, of course, too. When we manage anxiety, I want to normalize the concern. So when you notice yourself feeling anxious, I want you to normalize and validate these concerns because they are valid. This may not be like a snake phobia, right? Snakes may not be so scary. I'm terrified. I have a snake phobia. But that's something that may not be as valid as a fear of consequences of your cancer. It's valid that there's fear associated with cancer diagnosis and progression and or treatment. So that's normal and valid. I don't want you to dismiss that for yourself. And it's just because it's common and valid doesn't mean you shouldn't treat it, though. Doesn't mean that you can't make it better. But first, start with that validation. There's no help in fighting against it, really. So in CBT, cognitive behavioral therapy, we have this connection between thoughts, behaviors, and feelings in any situation. We work together to kind of outline this or make a diagram about this, similar to what you see here. And when we can identify both or all three of the thoughts, feelings, and behaviors and how they're connected, it gives us a lot of opportunity to intervene. So we could intervene where thoughts and feelings are connected, or we can intervene where thoughts and behaviors are connected, or feelings and behaviors. There's not one way to do this, but it's helpful when we can identify each part of this. So I was just working with a patient earlier with body image concerns. The thought specifically was, I don't want to go to that party because I feel like people are going to look at me and I'm wondering what they're saying. The feeling was shame and embarrassment, and the behavior was they didn't go. Now, there's a lot that we can change in there, but it takes some talking through and really some problem solving to address that. That's a very kind of basic model of what this looks like in real life. In CBT, we identify some unhelpful thinking styles. This is not a full list, but these are some very good examples, and we all do this. This isn't because somebody's doing anything wrong. You're not thinking wrong if you have some unhelpful thoughts. It's just kind of how our brain works, but a therapist will help you restructure some of those thoughts. So really the goal in that cognitive restructuring piece of cognitive behavioral therapy is to shift some unhelpful thoughts to something more balanced. That doesn't mean something unrealistic. That means something more balanced. And there's some questions that you can walk yourself through when you're noticing yourself in a really tricky thought. Here's your list of questions. For time, we won't go through that, but I want you to just take a look at that and think about how some of those questions might help you shift some of the ways that you're thinking sometimes. Also in cognitive behavioral therapy, we have behavior. So activity scheduling, making sure that you're doing things that are valuable to you, that are meaningful, that are productive. Also, it's easy to kind of let those things go when you're not feeling well, when you're feeling down, when you're depressed, when you're feeling sick, when you're feeling fatigued, when you're not getting sleep, when you're anxious. So we figure out a way to get these things back into your life. Acceptance and commitment therapy is different than cognitive behavioral therapy. I'm not going to quiz you on that, but acceptance and commitment therapy is really based on this idea of acceptance, which may not be a good word. You may not like that word. A lot of people don't. So here are some other terms instead of acceptance if you start thinking about this as related to your cancer. So the idea of letting go of the struggle or giving permission or allow it to be there, making room for it, soften up around it, or just let it be. Those are some other terms that we would use instead of acceptance, because sometimes we don't want to fully accept something, but we can learn to live with it. I talk about in acceptance commitment therapy, there's a lot of metaphor that's actually written into all the protocols that we have. But quicksand is a metaphor that we often use. So I don't know if anybody's ever been in quicksand. I hope you have not. But the idea is that in quicksand, we want to fight to get out. If I were kind of drowning in quicksand, I would fight my hardest to get out. But actually, that's not the way out. That fight is what keeps the struggle and what ends up pulling you down. In quicksand, just like in life, if we can make contact with, meaning spread out and take up space, and recognize and experience what's happening around us, all that quicksand, the more you touch it, kind of the more space you take up, it's more likely that you can get out of it. So that's a good kind of, I think, visual when we talk about quicksand for acceptance. Now, Dr. Clifton also talked about loneliness and social isolation. I don't need to tell you that roles change or it's isolating to go through cancer, but I want to share some questions with you. So just think about for a moment, where in your life are you prioritizing convenience over community? And are there places where that can shift? Convenience is necessary so many moments, but are there times in our life where convenience has taken over when we'd rather have connection? When was the last time I felt deeply connected? And this is a great practical question. Who in my life could I ask for help with this week or help this week, even in a small way? Usually when we ask of others, they're more comfortable asking of us. And that's truly how we connect. Some additional tips for connection are just making sure that you're reaching out, write a thank you note or a message to a person, contact somebody you haven't talked to in a while and share a meaningful memory to remember the time when we drop something off at a neighbor's door, schedule something with friends. So we have about 30 minutes left for questions. I want to share that list of resources again, and then share two groups that we host at Siteman for patients. So we have a mindfulness-based cancer recovery group and a metastatic cancer group. I want to remind you that if you're seeking any mental health support through cancer, that groups are often one of the best ways to do it. Some people don't feel comfortable in groups, and that's okay, but it really helps with that sense of connection as well as those skills that we were talking about earlier. All right, thank you all. We're ready for some questions, I think.
Awesome. Well, thank you so much to both of our amazing speakers. Just such great presentations and overviews. And I think the first thing I just want to touch on is, that's why we're doing this, right? We want people to know that they're not alone and that we're here and to create environments to all be together. And so just want to thank both speakers.